Good morning, everyone. Today we'll continue with our anatomy club presentation. Dr. Ashanga will talk about the ear anatomy.
Good morning, everyone. Today I will talk about the ear, which is somewhat delicate subject, but I try my best with the help of Dr. Ahmed to simplify this subject. The ear is divided into three parts: external and middle and internal ear. The external ear is consists of the two parts, which is the pinna, outer part of the ear, and external auditory meatus.
Just a second. أعطيني هاي الملزمة مالتك.
External auditory meatus, which is tube-like structure. Its length is 3.5 cm. Its outer part is cartilaginous, while in the inner two-third is bony, and all of them it is lined by the skin. While the middle it is in the tympanic membrane. This is tympanic membrane. The middle ear is slit-like cavity housed in the petraeus bone. Slit-like cavity housed in the petraeus bone, starting from the tympanic membrane and in the inner medially to the inner ear. This cavity has a recess, superior recess, which is called epitympanic recess or attic, which is posteriorly connected to the mastoid ear cell by the atidus. This cavity is room-like structure. This diagram will simplify to memorize the itis relationship. It has roof and floor, anterior and posterior, medial and lateral walls. The roof is thin sheet of the bone connected with the middle cranial fossa, while the roof.
It's called what?
Which is called
Tegment
tympani. Called
the roof is the tegment.
Tegment tympani. Okay. The floor is attached to the internal carotid, internal jugular vein. The posterior wall is connected with the mastoid ear cell by atidus, which is leading to the mastoid antrum. Also, the facial nerve has prominence on has a bony canal which has prominence on this wall, while the anterior wall is better seen in this picture, has connection with the nasal cavity, with the nasal cavity by the tube-like structure, which is called Eustachian tube, and attached to the itis muscle, which is called tensor tympani. Tensor tympani muscle. The medial wall has a prominence, which is called promontory prominence of the lateral semicircular canal of the middle ear, and there is two.
Where is it? This prominence of lateral semicircular? Nope.
I'm medial wall.
This is the lateral semicircular canal prominence. Okay?
Okay.
Adjacent to the facial nerve.
So.
Okay?
Okay. And there is two foramen in this wall. Windows in this wall, which is first is oval window, is attached. Oval window, which is the base of the stapes insert, and the round window, which is a canal for the third part of the facial nerve. This cavity has inside the cavity there is 3 ossicles, which is the first is malleus and stabius and incus. This these bones are joined together by the synovial joints.
And they are the smallest bones in the body.
In the body. This is malleus, and this is stabius. This is incus.
Where's the stabius? Yeah, the one. No, the small one sitting on the inner ear is the stabius.
This is malleus. This is the most important radiological pair of the scutum, which is a bony prominence in which the tympanic membrane is attached. This is important.
Scutum is the site of attachment of the tympanic membrane. Tympanic membrane and edge malta
scutum. This is very important when it is eroded. It means that it is sensitive marker for middle ear disease, when there, especially cholesteatoma or infection through it. When it is eroded, the infection will go to the middle ear and to the mastoid ear cell, then related posteriorly to the sigmoid sinus and in the cerebellum and posterior cranial fossa, or directly through the atidus, through the tegment tympani, to the middle cranial fossa.
Atidus will lead to where?
Atidus will lead to the mastoid ear cell.
Tegment
tympani to the middle membrane, middle cranial fossa.
If something extends through the atidus, it will go into the mastoid ear cells. If something goes through the tegment tympani, it will go to the cranial fossa. Okay? Should keep
middle
that in
cranial fossa. Yeah. Now, the inner ear is a membranous system of fluid-filled sac concerned with the hearing and balance, and it is housed in the protective labyrinth of the dense bone and lie in the petrous bone medial to the middle ear. The bony labyrinth consists of a vestibule, which is communicate posteriorly with the 3 semicircular canal and anteriorly with the spiral cochlea. This picture. This is 3 semicircular canal, and this is the cochlea. Both the semicircular canal are leading to the ampulla, and the ampulla will lead to the utricle. While the cochlear lead to the ductus rhenion, and then into the saccule. The saccule and utricle joining together in this area and leading to the epitympanic duct, which is end in the blind sac, endolymphatic duct, and blind end, which is called endolymphatic sac.
Good.
The bony covering of the lateral semicircular canal bulge the cochlear duct extends from the cochlear to the perilymphatic continuous with the CSF of the subarachnoid space at the vestibular aqueduct. The cochlear.
So the perilymph, in fact, is just a CSF. Okay, بالهرمونولوجي هو CSF. It opens into the brain, into the cranial cavity through the aqueduct, the vestibular aqueduct.
The cochlea has 2.5 or 2 and 3/4 of the turn. This is
2 turns and a half. Okay.
Its apex is perpendicular to the petrous bone.
Okay.
It has bony cochlear central
Central modulus.
modulus from which the shelf of the spiral lamina project.
When it mimics the turns, there is, you don't see it here, there is مثل like شلون stairs مثل درج that's turning. On it, this is called the modulus. Okay, on it is the cells that are sensitive to hearing.
Internal auditory canal, meatus, is a bony canal of 1 cm. This is internal auditory canal. Is a bony canal 1 cm in length. Transmit the 7th and 8th cranial nerve from the posterior cranial fossa. The lateral extent is separated from the inner ear by the perforated plate of the bone. The crest on this bone is called crista falciparum. Divide the canal into upper and lower. This is for just for memorizing it. This is the crista falciparum, and the upper part is 7 cranial fossa, 7 facial nerve, and the lower part is cochlear nerve, 7 superior vestibular nerve, and lower part is inferior vestibular portion of the
and
vestibular.
This is of very high big importance in people planning to undergo cochlear implant.
cochlear implant, yes.
cochlear implant لازم نشوف واحد ولا أربعة. Okay.
The radiology of the middle and inner ear, the plain film has little importance nowadays because it has been superseded by the CT and MRI. If you want to see it, it will straight occipitofrontal skull X-ray is appear in this view. Computed tomography image may be obtained in both axial and coronal. High resolution scanning is of the temporal bone can image the cochlear, vestibular, semicircular canal, ossicles, and bony canal of the facial nerve in axial and coronal planes, while a high cut through the petrous bone, two limb of the superior semicircular canal may be seen.
High resolution scanning of the temporal bone. How much is the slice thickness? Would you recommend?
2 millimeter.
2 millimeters too much. 1 and less. 1 millimeter, if possible, 0.8, 0.7 millimeter, even better. Okay, 2 millimeters too much.
This is CT. This is the CT showing that this is internal ear, internal auditory meatus, and this is cochlear terms. Internal. This is the pinna and external ear. Okay, this is cochlear terms, and this is semicircular. I think yes. This is semicircular. Semicircular canals, and this is vestibule. This is facial nerve. This is facial bony canal of the facial nerve, and this is middle ear and epitympanic recess. This is ossicles, malus, and the
ice comb appearance. Looks like an ice cream comb. You always look for that. مثل ice. هذا ice cream أبو البسكت. Okay.
This is epitympanic recess, and this is mastoid ear cell. This is Atidas.
Yep. Again, هذا شنو الفرق عن what's the difference between this one and the previous image?
This was axial, and this is coronal.
Where is the coronal? This is the
هذا
axial.
coronal.
This is the axial. Go next.
دقيقة.
This
هذا coronal لأن middle ear يعني outer ear appear. Okay.
حتى بالاكزيال outer ear appear. But you have
appear,
no knowledge.
but يعني the picture end in the outer ear.
Okay.
هنا ماكو.
Okay. So this is axial.
Axial.
And
this is coronal.
Nice.
Coronal is external auditory meatus, and this is internal auditory meatus. This is
Crista falciformis.
crista falciform, and this is a turn of the cochlea.
Good.
And this is semicircular canal. This is facial nerve.
Yep.
And this is epitympanic recess. This is mastoid air cell, and this is scutum.
So, question: why this image is sharper and more detailed than this one? This is very sharp, very well defined.
Yes.
Why this is little bit less? Why is that?
Constructed.
Because this is a reconstructed image.
Reconstructed, yes.
We don't make CT scan in the coronal plane
Coronal
directly.
plane.
You make an axial, reconstruct into coronal. It will never be like the original one. Okay? يعني اخذ لك صورة ما تطلع مثل ما اشوفك شخصيا ايش ما يكون الكاميرا.
This is cochlear duct, and this is vestibular duct, which is end into cranial.
Into the brain.
Brain. Cranial.
مو brain, the
Cranial.
cranial cavity. Okay.
MRI also can be used for the visualization of the middle and inner ear. The MRI used for study the content of the temporal bone and able to image in any plane. In contrast to the CT. The coronal image demonstrates the content of the internal auditory canal and facial and cochlear nerve. The loop of the anterior inferior cerebellar artery as it is coiled near the internal auditory meatus is often visible and should not be mistaken with the pathology. The cochlea and vestibular may also be identified, and these are fluid-filled and a high signal intensity in T2 weighted MRI. Neither CT and MRI cannot distinguish to membranous labyrinth from the fluid body labyrinth in which it is lie. The most important radiological pair is that the CT and MRI is important period to the placement of the cochlear implant, and intact cochlear normal turns of an intact vestibulocochlear nerve are requirement for successful implant. This is MRI. This is semicircular canal.
What's the sequence of MRI? This
Sequence T2.
what kind of T2? Yani we do T2 for the brain, for the. It will not be like that. What's the difference here? This is MIP, maximum intensity projection, like myelogram, like MRCP, for example. All of these, it shows the signal of the fluid to the maximum. You can see here everything white is fluid. Okay, and the internal acoustic canal and the cochlea and the semicircular canals, all of them filled with the fluid. That's why we see it so obviously. Okay.
This is semicircular canal. This is cochlea. This is cochleovestibular duct. This is the blind of the endolymphatic duct.
Nice.
Now, turning to another subject, which is pharynx. The pharynx is a muscular tube extending from the base of the skull to the level of the cricoid cartilage, approximately C6, and where it is continuous with the esophagus. It lie behind. This is the pharynx. It is starting from the base of the skull to the cricoid cartilage at the level of the C6, and it is opened in the nasal cavity and forming the opening of the respiratory tract, and from the to the oral cavity, forming the opening of the gastrointestinal tract. It has three muscular layers. No, it has three coats: mucus coat and submucous layer, and which is called pharyngobacillar fascia, and the outermost coat is constrictor muscle. It has three muscles, which three constrictor muscles: superior and middle and inferior. Superior constrictor muscle is arise from the trigoid bone to the inner part of the mandible, while the middle and into the hyoid bone, and the superior and the stylo-trigoid fascia. Stylopharyngeals, while the inferior constrictor is end into the thyroid and cricoid cartilage.
So there is superior, middle, and inferior constrictor.
And inferior constrictor. This inferior constrictor is oblique and horizontal line, so it will be oblique, and the horizontal fiber become a weak spot for the Killian's dehiscence, through which the pharyngeal pouch may be emerged. The constrictor muscle is covered by the loose buccopharyngeal fascia, which is continuous with the fascia covering the buccinator muscle. The pharynx is divided into three parts: nasopharynx, oropharynx, and laryngopharynx. Nasopharynx is a part between the posterior conal and the lower limit of the soft palate, and communicate anteriorly with the nasal cavity and inferiorly with the oropharynx. The roof of the is bounded by the inferior surface of the sphenoid. The roof is bounded by the superior surface of the sphenoid. Inferior surface of the sphenoid and the clavus.
Only skull base.
Only skull base. It open in the nasal cavity, and it has opening in the lateral wall, which is open into the opening of the Eustachian tube. It has a thickening in the opening, which is called torus tuberous.
Torus tuberous. And where the exact anatomical opening of the Eustachian tube? What's called?
Opening.
Opens where in the pharynx?
Pharynx. Lateral wall.
Lateral. What did
they
call
nasal.
it? They call it fossa of
Rosenmoller.
Okay. It is تقريبا the most important thing to identify in the head imaging. You have to identify fossa of Rosenmoller because it's the most common location of nasopharyngeal carcinoma. Okay. Number one, you identify fossa of Rosenmoller.
There is a recess behind it, which is called parapharyngeal recess. It has multiple muscles, which the most important is tensor. This is levator valley muscles and tensor valley muscles, and superior constrictor muscle also, and stylopharyngeus muscle. Lymphoid tissue lying in the nasopharynx are prominent superiorly, forming adenoid, which is called adenoid, while the lymphatic drainage of the nasopharynx it is related space into the jugulo-digastric node, which is lying in the angle of the mandible.
And it is the largest lymph node there. So normally you see it large, prominent. Don't be worried. It's normally like that. It's just large lymph node. Jugulo-digastric node.
Okay. There is different multiple spaces related to the nasopharynx, which is most delicate subject is parapharyngeal space, is a slit-like space just lateral to the nasopharynx, extending down to the base of the from the base of the skull, and this space bounded by the buccopharyngeal fascia. This parapharyngeal space lateral to the nasopharynx, and
This parapharyngeal space is important. Normally it contains what?
normally contained
The most
external carotid
the most
artery
prominent content filled with what?
is
Fat. It's usually filled with fat. Contains the
external carotid
I don't know
and
what
the
vein,
pharyngeal vein
mandibular
and
vein, but
mandibular
it
vein.
mainly contains fat. When you lose the fat in the parapharyngeal space,
Mean
there is something
carcinoma. Yeah, in pathology.
suspicious. Okay? Most likely carcinoma.
Carcinoma. Posteriorly, it's separated from the carotid sheath, and this is the tensor tympani and the styloid process.
Okay.
And this is
What
para.
is it?
This is the styloid process.
Number 12.
Aye.
Yep. It's filled with black thing,
Yes.
which is
Fat.
fat. Okay? It contains fat. So, where is the fossa of Rosenmiller here?
Fossa of this styloid. This Eustachian tube. Aye.
Where is the fossa of Rosenmiller? Not the Eustachian tube.
Aye.
This is it. Number 3.
Mm.
Okay? So, you can see the relation between fossa of Rosenmiller and the parapharyngeal space. They are very close to each other. And that's why the most common location of nasopharyngeal carcinoma is the fossa of Rosenmiller, and when it extends to the adjacent parapharyngeal space. You should make use of the fact that it should contain only fat. When it contains anything other than fat, there is something suspicious.
Another space is infratemporal space. This is infratemporal space. Lateral to the nasopharynx and parapharyngeal space behind the posterior wall of the maxilla, and it is extend from the base of the skull to the hyoid bone, to the hyoid bone, and contain the trigoid. It contains the trigoid muscle, and it is continuous superior with the temporal fossa through the gaps. The roof is formed by the inferior surface of the middle cranial fossa, laterally bounded by the zygomatic arch. This is a infratemporal space, I think. Yes, infratemporal fossa.
The name is very obvious. Infratemporal. You look for temporal below it.
Below it, down to the hyoid bone. The space deep part of the parotid gland. This is the deep part of the parotid gland is lateral to it.
Okay.
Yeah, inferior and lateral to it.
What? Should be deep part of the parotid gland.
This is the deep part of the parotid gland,
Okay.
which is lie in the ramus of the is lateral to, and lateral and inferior.
Okay.
This anterior to the deep part. This space anterior to the deep
Okay.
part. The anteromedially limited by the junction of the lateral trigoid palate, and posteriormedial limited by the maxilla and superior.
No. Anteromedially. رجع.
أرجع على الرسم.
لا ارجع على السلايد. وين؟ Anteromedially. The
Limited.
infratemporal fossa, there will be anterior and medial, هو lateral trigoid plate with the posterior medial limit of the maxilla. Okay?
Why anterior?
يعني posterior wall of the maxilla is the anterior limit of the infratemporal fossa.
يعني هنا.
يعني if I tell you she's on axial not on the lateral. يعني if I tell you where is the infratemporal fossa, you look for the parotid gland, you look for the deep lobe, go anterior to it.
Yes.
Okay? Or you look for the maxillary sinus, you look for the posterior wall, and you go posterior to it.
Another fossa is trigopalatine fossa. It's medial depression of the trigomaxillary fissure, lying just below the apex of the orbit. Between the trigoid process and the posterior maxilla. Its medial margin is perpendicular plate of the palatine bone. Its important content is connected to the several space and maybe facilitate the spread of the pathology between them. Communicate superiorly with the orbit. So posterior part
It's
of
like
inferior
the
orbital
train
fissure.
station of the head. All compartments are connected to it. So whenever disease is going there, it can go anywhere. It can go to orbit, to infratemporal, to brain, whatever.
Connect. This is connected to the orbit, to the fissure, orbital fissure, and to the temporal bone, and inferiorly foramen rotunda open in the its superior.
رجعت لي قبل تايم وين هذا الكوميونيكيشن كنتي كاتبتها حلو. Okay, so communicate superior with the orbit through the posterior part of the inferior orbital fissure. بس وين بقيت الكوميونيكيشنز؟
And it communicates superiorly with the orbit. هاي
تمام.
The foramen rotundum open in the superiorly and connecting to the middle cranial fossa, while laterally,
so it can spread to the brain, to the middle cranial fossa, to the orbit. Where else?
Laterally communicate freely to the infratemporal fossa.
infratemporal fossa هم يروح. زين.
Medially to the nasal cavity.
Medially to the nasal cavity. يعني it can go to the nasal cavity, to the brain, to the orbit, to the infratemporal fossa. All of them opens into this tiny space.
And oral cavity through the greater palatine canal.
Okay.
Which run inferiorly between the palatine bone and maxilla. The fossa contain the maxillary division of the fifth cranial nerve, which is run through the foramen rotundum and into the orbit via the inferior orbital fissure. And it also contain the trigopalatine segment of the maxillary artery.
Good. I think back here. Okay, we should stop here and we'll continue next week because time is, I don't want any problems.